This is an easy question for whoever wants it. Why does the hospital care how many CAT scans we do? The CAT scanner is paid for, the techs are on duty. It's just dollars. They make it up.
Anybody? I think that has your name on it, Mike.
So I absolutely agree with the economics that were just raised, which is on the margin, that extra CAT scan costs the hospital itself nothing. But they're now entering into contracts where they're graded based on utilization. So Medicare Shared Savings Project or an ACO, more CAT scans equals less of that bonus money coming back to the hospital. There's a group of folks here from the state of Maryland. More CAT scans equals maybe losing the DRG waiver for the entire state. So we're all on the hook for the utilization, and the economics, both are playing in parallel. On the margin, that extra CAT scan in the middle of the night, it actually costs nothing. You're right.
Anybody else want to add?
Well, there's a patient safety concern, obviously, as well with getting more and more CTs. But, you know, as Mike said, we're going to be on value-based contracts. Ultimately, we're going to be on some sort of risk share, and we're going to have to look at using guidelines, as I mentioned. And so the economics of it, they probably do care in some sense, because they will be having these risk-based or risk-sharing contracts, and that will affect their bottom line. So plus it's the right thing to do from a medical standpoint, to be honest with you.
Does everybody remember OP15? You remember that? Okay, so that's an example of what I think we all think is likely to be coming. That was where you were going to be dinged if you ordered a CAT scan, and it was normal. And CMS was going to track this diligently. Thank goodness, ASAP through the QPC, we had that one pulled back. But that's what's sort of getting ready to roll out, my friends.
That measure was all CTs versus and positive CTs. Didn't matter the indication. It was such a general, measure that had really no reality other than just numbers of CTs and what were positive. It didn't look at appropriate utilization, and that's why ASEP was really against that measure. Ultimately, we do need to look at appropriate utilization, whether the choosing wisely, other areas we need to look at appropriate utilization, but that OP15 was really a disgrace.
It was driven by radiology, wasn't it?
Yes.
Yeah.
Sure.
Okay, in the back? And do you want to direct it to someone, or?
I think it mainly would be to Mr. Edmondson.
Here you go, our resident suit.
My question is, with looking forward at all the savings plans we're looking at, getting the right patient to the right place at the right time, it seems to be the big elephant in the room in my mind is all this seems to be predicated on a primary care system that has the capacity to handle the demand. We're moving forward, and things are going to get more efficient, but where's that workforce? And, we get mid-levels, et cetera, but where's
Right.
that workforce? I don't know of them coming up. How is that going to work?
That's a huge issue. I completely agree with you. I agree that the mid-levels, the advanced practitioners, the theory is that they're going to pick up a lot of that slack. But you're right. Right now, there is not the capacity. If we're going to start shifting some of this business, out there, there's not the capacity. And the other problem, we talk about this all the time, the younger physicians, they don't want to work till 8 o'clock at night in their practices. They want to leave at 5 o'clock. That to me is almost a bigger issue that we're facing.
Because this is, in order to get these folks, this is going to be an 8-year process.
Right.
They need to be touched in medical school and make it.
Exactly.
And then to the primary care field. So we're at least, in my mind, what I've read, at least 8 years off from any of that.
I agree with that.
The department we are the access.
Absolutely. Other comments?
This is on the way back. Yeah, we're on our way back to our expert here, but I don't understand the economics of the new generation of physicians, because they come out $1 zillion in debt, and they can't work limited hours. That just simply isn't going to work. And we have a big issue that Dave may be addressing, that eventually having a medical degree may not be economically viable.
And we'll certainly look at changing the way medical school is done in terms of competencies and perhaps shortening that. But I will say what is we almost do have the capacity right now, and it's being made up by nurse practitioners and PAs. And I actually think in my talk, retail medicine, I think, is going to help fill that gap. If you're age 20 to 55, 60, and you don't have many medical problems, convenience trumps coordination any day, all right? That's why our EDs are filled up. But ultimately, if it's going to cost me a lot of money because I've got this big, huge deductible, I actually think retail medicine is going to start filling that gaps of the convenience care. I think telemedicine is going to start filling that gaps. How many of you, when you go to see your doctor now, you're fairly healthy, you don't even see the doctor often. They might see you because you're the doctor, but most people, don't see the physician when they're reasonably well. They see the nurse practitioner. I know my mom sees the nurse practitioner or PA. And so that is filling the gap, and that's a very, a reality in terms of primary care. Ultimately, as we get to older patients that have more complexity, I think we will start running into some problems because after age whatever, I have to be careful, it might be 55 today, next year will be 60. But when you start developing medical problems, you are going to need better coordination. I think we will run into some problems there. But I think that low acuity is going to be picked up by nurse practitioners, retail care, and telemedicine.
Texas probably has the most aggressive tort reform in the country, and the early studies that are coming out that I'm aware of, maybe Tim C., if he's still here, is aware of others, are showing really no difference in defensive medicine practice after tort reform. So I never thought that was an issue with emergency physicians because we don't have a stake in the ancillary revenue, but it certainly is in the office. Early in my career, I served in a part-time role as a medical director for AvMed HMO as a utilization review doctor, and I had 14 nurses looking at cases. I actually wonder if big data isn't driving us back toward prepaid because much of the healthcare system is already prepaid. Probably 70-75% of our visits in the department are prepaid. But we had a big fight with the urologists who were all banded together in Dallas-Fort Worth about the number of TURPs, transurethral prostatectomies. And so we finally beat them into submission and put them on prepaid. The number of TURPs dropped by 50%. And of course, they could justify all those TURPs before that change, and they could justify why all of them weren't necessary afterward. And from my knowledge, the malpractice rate on urologists did not increase with that change.
As in my talk earlier today, it is the choosing wisely hasn't dealt with the supply side. It's all on the demand side, and we are going to. And once you change the rules, you do decrease the number of procedures. We'll see that as more and more risk-based contract, more and more prepaid come. We're going to see caths probably going down, hip replacements, and a lot of other procedures going down in numbers.
I know you must have more questions. Let me remind you what you've heard today. You've heard about some design issues. You've heard about getting paid in 2016 and beyond, boarding. Am I jarring any questions there that are coming to the surface? Oh, see, hands. I love this. But I believe yours was first.
Well, this is along the lines of value-based purchasing and pay-for-performance. One of the components of those is patient experience, and I'm sure everybody in the room is struggling to improve patient experience. Can you talk about that a little bit in terms of physician reimbursement, hospital reimbursement, and how we get buy-in from physicians related to that in terms of the reimbursement structure?
So he's asking about the experience of care and reimbursement. Who wanted to take that? Mike, it looked like it was coming your way. Are you catching?
So right now, hospitals have a very significant amount at stake related to the HCAP programs. We will have ED caps that are specific to our outpatient unique setting. Things like how easy was it to schedule an appointment are obviously a strange fit. I'm thinking you're on the hospital side of the world, perhaps, is that
No.
Not, okay, great. So how do we get physician buy-in for what now are really hospital-based measures? And it's the same way we get physician buy-in for everything that relates to the hospital. How do we create value for our hospital-based partner? And I have seen across maybe a handful of groups, mostly in the Midwest, that the hospital service agreement actually ties in the metrics that relate to the HCAHPS. It could be for United Healthcare or it could be for Medicare, and that the group agrees prospectively to hit certain thresholds. Right now, maybe the thresholds for the private payers aren't that well formulated, so it's just best efforts at upcoming quality programs. So it becomes, and I know Ron's spoken about sort of the evolution of the Democratic group. If we want to keep contracts, we're going to have to add value in the patient experience realm. When we look at the way our individual providers are compensated, RVU production is just one little thing. We don't want RVU machines at the bedside zipping in and out of rooms, and the quality component has to be part of that with patient satisfaction.
Oh, I just wanted to chime in. How do you get doctors to buy in? So listen to this fabulous solution to boarding. Medical University of South Carolina. Anybody from that neighborhood? Their new CEO started and informed all service line leaders, every service, including medicine, surgery, every service, your pay is going to be tied to quality metrics that you share with the ER. Because we've got a problem with boarding, and guess what now? It's your problem. July 1st, Chief of Medicine took call in the hospital with his new interns, informed everyone that they were to respond to the ER in a timely fashion, in a very polite manner, and they were not to push back against admissions. They were to take them with open arms. Can you imagine what changed? It was overnight. Don't you love this? I mean, this is an idea worth taking home. And it was so simple. You know what? Your performance and your reimbursement are going to be tied to your colleagues in the ER. What a lovely idea, right? We're talking all this chatter about alignment, and now here's a place, and oh, by the way, a teaching hospital doing this, that is actually really doing it. So now we're all aligned. The internal medicine dudes and dudettes and little interns and so forth are all aligned with me in getting my admissions upstairs as quickly as possible because length of stay is being tracked. What a lovely thing. Anybody else heard of anything like that, or anybody doing that at your facility where you're aligning all the service lines on length of stay measures for patients that start in the emergency room? It's a beautiful thing. There were some more questions in the back.
I just had a question. So, I'm a hospitalist, and for us in internal medicine hospitals are used to being part of groups, with a multi-specialty group, but ER has always been out on their own on an island, their group, they're not part of another group. So how does it feel being now, with the move to clinical integration and ACOs, you're forced to be part of a bigger group? How is the ED physician community adjusting to the idea now we are part of a bigger group versus we're on our own on an island?
Yep. So for the back, the question is about integrating the hospitalists. We have a hospitalist with us who's wondering how integration has gone when you add hospitalists to the emergency physicians and others and make them partners. So Team Health is making this part of their corporate way of doing business. And I'm going to speak because in a couple places where I have worked, big, high admission rate hospitals, where the hospitalists were linked to us at the belt. So I knew today when I was on call, my hospitalist was going to be there with me the entire shift because that's how busy they are. And my job is to be able to work with him facilitating the flow of patients. He needs to know what I'm working on. I need to know what availability he has and if he's going to be distracted by other duties. It's completely refreshing. So I went from Ohio, where I had no hospitalists, to Atlanta, Georgia, Emory, which had 3 hospitalist groups competing for business. And so these guys are wanting to be down here with me. It's stunningly different practice than where you're in an antagonistic situation with the hospitalist or other members of the medical staff. I'll let somebody else reply with their experiences.
The high-volume utilizers, another small software company I worked with is called Loopback Analytics, and their purpose was to try to facilitate transitions of care. But your high utilizers are typically, it's a 3-legged stool. It's the hospitalist, it's the emergency doc, and it's the nursing home doctor. So many of the hospitalist groups that I've worked with have added nursing home coverage to their group so that they control all three legs of that stool. And they've had some pretty good success at it, as well as institute things like a congestive heart failure clinic adjacent to the emergency department.
A little different perspective with my group is we had that issue with the relationship between the ED
You're going to have to stand up.
and the hospitalist. Then we had, so we decided that we would kind of create our own hospitalist service. We were not employed by the hospital. There were 2 employee services at the hospital system. And so we took this to the administration because we didn't feel like they were meeting our needs and it was too much of a hassle factor. And we said, you know, we're going to hire some internists that are going to work with us in the hospital, and we'll take some of this load off of your hospital services. They're saying that you're too overcrowded, there's too much work, and that immediately got squashed by the physicians that are in charge of the hospital service. And then don't you know that suddenly, you know, they were more welcoming of our patients and everything, and they saw that as revenue. And so we decided to solve our own problem, and then put the pressure on them, and they came back around, and now it's not much of an issue anymore.
Yeah, I think it clearly the hospitals and emergency physicians are really should be integrated, and they really are in an alliance, and that is part of the business model of some of the large emergency medicine groups. But I think it provides an opportunity to get into leadership, to take when you develop problems, the hospital administrators don't want to hear complaints. They want to hear solutions. They want you to come in with how you could fix these things. And I think increasing those working related, that's what an integrated network is. It's working with people to help find solutions. And frankly, emergency physicians are really well qualified to do that, because we have to deal with all the different groups. We have to sell our admissions sometimes. We have to advocate for our patients. But we've got to come in as a united group and help the hospital find solutions, not just deal with complaints that we're overcrowded or I'm getting too many admissions. We've got to help find solutions. I really think this opportunity, this whole value-based care really provides an opportunity, particularly for emergency physicians, but I think physicians in general, to help find solutions to shape our future.
Weren't there some questions in the back? Yes, checkered shirt. And can you tell me who you want to direct it to, or? Okay.
About you mentioned in your great talk on observation medicine about the cost saving for patients. What I think you maybe meant was for the patient's insurance company. I was wondering if you could address, if you know of any data on the average out-of-pocket costs.
Great question.
Status versus inpatient, and how do you address what you brought up earlier about if I'm going to come in under observation, then we're not staying.
Yeah, great question. And in the 1-hour ops lecture I do, there are 3 full slides, about 7 or 8 minutes devoted to patient financial considerations. I think I heard a lot of groans throughout here when folks are being tasked with having what's really a cashier conversation at the bedside while wearing a white coat. It's absolutely the wrong role for us. And I'll explain it all so that we have some shared knowledge, but I don't think it's a conversation that as a clinical ER doc seeing a 52-year-old with chest pain we should be having at the bedside. That's a professional, scripted process that should take place from the registrar, not from the doctor taking care of the patient. That being said, here's the background. Medicare Part A has a deductible that resets every 60 days. In 2016, it's $1,288. If that low-risk chest pain patient becomes an inpatient, they will pay the first $1,288 of their bill. Their DRG payment will be a little bit more than that. It'll be about $4,500. The patient takeaway cost for that inpatient stay, low-risk chest pain, is about $1,300. If they're an observation patient, it's an outpatient process. It falls under Medicare Part B. Medicare Part B has 20% coinsurance, and that's the thing that the AARP has gotten everybody revved up about. Well, let's do the math together. The OBS payment that increased significantly for 2016, it's only $2,000. The patient cost share is only $400. What's not covered then are the self-administered meds, and that's a real issue. So if we order Zestral for a patient, the hospital's charge master has that Zestral at $178. In the OIG report that started the 2 midnight rule, the average out-of-pocket expense for self-administered meds was $512. Even if the patient had all of the self-administered med costs, they're up to $912. It's actually cheaper to be in observation unless you have a very, very long stay. For the types of patients that we would take care of in an ED-run OBS unit, TIA, chest pain, syncope, it's actually much less. I have parents in their late 70s, they have medical issues. I always have them in observation status unless they're having, some long and lengthy procedures performed. The self-administered medication issue is real, and there are a lot of creative processes that have developed. We did a straw poll in the ASAP OBS section. We had about 30 respondents, and 2/3 of those hospitals that responded came up with some creative solution for self-administered meds. You do not have to charge the patient for the meds, so they can literally be free. It's not a Stark issue. Or you can have the patient bring the meds from home. We don't want them really in the line of fire for the $178 Zestral. And the last issue that comes up is, we're going to be bankrupt because we're going to need a skilled nursing facility care after the OBS unit. For that TIA, chest pain, syncope patient, we will not be sending them to a SNF. In the OIG 2 midnight study, there were only 6 patients that required SNF care, and they all had 3 or 4 day OBS stays. And I'm happy to talk more about the SNF, but it becomes a little more complicated.
Any other questions?
This is for Dr. Helsner. So, with respect to your talk on the Democratic group, if you're a Democratic group, a single hospital, and you want to present, you present a couple different options. Number one is you get sold to a bigger group, or you try to regionalize. When you bring that topic up to your CFO or your CEO of that hospital, how does that bring value to that hospital system? The way I'm looking at it, the hospital system, why wouldn't we just contract with that bigger group in the first place? Or you go to be regionalized, especially if you're trying to go to another hospital who might be a competitor, they may look at that as
So is your question, if you bring up this subject of selling to another group with the hospital, what the hospital's reaction would be? It depends. It depends on your relationships, I think. If it's sold on the basis that you're going to bring all this additional practice management capacity and IT depth in, the hospital may well say, well, that's fine. If you're not secure in your position, in your relationships and whatnot, they might just say, well, we're just going to hire the other group. So I think it's very dependent on the relationships that you have as to what course they would take.